Hello, everyone. Thanks for coming. My name's Clint Collins. I'm a urologist with McKeever Clinic in Jacksonville, Florida. And tonight we're going to talk about one of the treatment options for uh, prostate cancer and enlarged prostate in general. Um, we'll talk about symptoms, how we treat it, uh, how we diagnose problems, and give you an idea of what some options might be. So when we get started, you're going to have an option to chat and ask some questions, and we'll try and address those at the end. All right, so tonight we're going to, some of you may know some of the things that we're going to discuss because some of this is somewhat basic, but for those of you who don't really know much about the prostate, we're going to talk about, why you have a prostate, what its importance is, what is BPH or benign prostatic hypertrophy or hyperplasia, how do we diagnose that, what options do we have to treat it, and then tonight we're going to focus a little bit on something called the UroLift system, which is one of the treatment options, minimally invasive treatment options for this. So, what is the prostate? It's a small little gland. It's about the size of a walnut. It surrounds your urethra. It's located right underneath your bladder. So your urine channel has to flow through the prostate to get out. And it does, as far as like, why is it there? What does it do? It produces fluid that adds to the semen volume. It's important in reproduction, and that's why we have that. So as far as, when your prostate grows, as you can see, as you're into adolescence, it's growing significantly. But then as we age, between the ages of 35 and older, we're seeing more and more growth. Next slide. So what some of the issues that we can see related to the prostate are infections or inflammation of the prostate, which is referred to as prostatitis. There is a cancer involving the prostate that almost everyone has heard of. It's a very common cancer in men. Usually it's slow growing, but some men can die from prostate cancer. And then there's benign enlargement. So when the prostate gland enlarges, you can have varying degree of urinary symptoms. All of these symptoms, you can have different symptoms from each of these conditions, although some of the conditions can produce the same symptoms. So having one condition doesn't mean you don't have another. And again, it's really important that you see a urologist about any of the symptoms. So as far as percentage of people that, as you age, as you see here, these pie graphs, by age 50, about 40% of men are going to have an enlarged prostate and some symptoms associated with that. And then as you age, that increases dramatically. Almost every man in his 80s is going to have some trouble. 40 million men each year are affected. And again, by ages 70 and 80, almost every man is affected. All right, next slide. So what is BPH, or benign prostatic hyperplasia? It's the fancy clinical term for enlarged prostate and the things that can go along with that. It is non-cancerous. It's benign enlargement of the prostate gland. So it does not predict cancer. It does not give you a higher risk of cancer. PSA, or prostate-specific antigen, is one of those blood tests that many of you may be familiar with. It's a screening tool for prostate cancer, but it does rise as your prostate enlarges with benign growth. So some of the guys that have really big prostates and dramatic symptoms, or I guess they don't even necessarily have dramatic symptoms sometimes, as we'll see later. But as your prostate grows, it will tend to produce more PSA. So as we know, this is it's a screening tool, but I guess the point being here is that we see PSA rising with benign growth and prostate cancer. So what is normal and what's abnormal? So as the prostate enlarges, you can imagine and see here how it can encroach or squeeze into the urine channel and obstruct flow. So that causes many symptoms. Some people, have worse symptoms than other with varying degrees of enlargement. But as I've got some patients who we do a volume measurement of their prostate, and I'm surprised that their symptoms are so minimal given the size of their prostate. And then I have men that have moderately enlarged prostates and they're miserable. So the size alone does not always give you the degree of bother or the degree of obstruction, although it is important when we talk about treatment options. Next slide. So as we've said, it's benign, so it's non-cancerous, but it doesn't mean that it doesn't cause trouble or problems. As your prostate is blocking up the bladder's now working harder and harder over time, many years, as the prostate gland grows slowly with time, the bladder is going to have to fight that slowly over time. So many men, their symptoms may change, but it's not so dramatic because it happens so slowly. But as you can see here, this is a cartoon, but the bladder on the right is, you see these webs, those are thick webs of a different collagen, and the bladder itself has become thickened, and you're losing a capacity. So you're losing the amount of urine you can store in your bladder. It can become overactive. It can become underactive. So by not treating even benign enlargement with maybe even with moderate symptoms, the bladder can actually the bladder function can become a problem, and you can have irreversible damage there. Next slide. So as you can see here at the top of our screen, we're seeing a cartoon depiction of the benign tumor, because it is a tumor, but it's benign. It's a benign growth, or adenoma to be specific, but that begins to grow usually in the central portion of the prostate, and that white stuff there that you're seeing inside the prostate is growing around the urethra, and it can eventually take up and push all the other tissue out of the way, and you're dealing with a very large hypertrophied gland. And on the bottom of the screen, we're seeing cystoscopic, or we're going in with a scope and we're looking into the bladder. So that black that you can see in in the middle of that first picture on the left, that would be me going into the bladder. If I went through that black hole, and you would see the bladder itself, and you can see it's wide open. That's a good channel. That person's going to have a good flow of urine as long as their bladder works. The second picture on the bottom, you're starting to see these what we call lateral lobes, or I talk to people and call it I mention it like an apple, with the core of the apple being the urethra, and the apple itself kind of pushing in on that core. And in the middle there, you can see that it's starting to do that. And then on the bottom right, that's when we're dealing with a very hypertrophied gland, lateral lobe. Lateral lobes are pushing in and obstructing the flow. You don't see that nice open channel anymore. So what are the symptoms and how can we recognize them? So again, these are somewhat, they're non-specific symptoms, but men that have enlarged prostates will often have frequent urination, which translates into many trips to the bathroom. Urgency can be a problem, so having a hard time holding your urine when you need to go, or postponing urination. You're having a difficult time postponing urination. Can sometimes become painful. It's usually not, but you can have some painful urination. The weak stream, while that's one of the biggest things men mention, it's just that it takes them longer to go to the bathroom, and they're having to stand in front of a urinal for, a lot longer than they were before, and not feeling like they're emptying their bladder, or either actually not emptying their bladder. Intermittency, that's stopping and starting a flow. So you go and it stops, and you kind of either have to push, or it goes again, and it's a stop and go kind of thing. Next slide. We talk about quality of life with BPH, because like usually it doesn't kill you. Severe obstruction of your urinary tract can give you kidney failure, but that's more rare. But in absence of that, BPH is not going to kill anybody, but it can greatly change their quality of life. And so some men can't go on long car trips. They don't like to fly, because they're worried if they're going to be able to go to the bathroom. They can't go to football games and concerts and things like that, even church and that sort of thing. They may go to the bathroom stall instead of urinals, because they're either embarrassed about their flow, or they have to sit to urinate sometimes. And then, what we call nocturia, or getting up a lot in the middle of the night to urinate, is one of the biggest bothers. We have, some men are getting up every 30 minutes to an hour to urinate. So how do we diagnose this and figure out if this is what we're dealing with? So we're going to ask you lots of questions. We're going to inquire as to, if any of that stuff's happening. It's part of the physical exam, and involves running a little ultrasound device over the bladder to see if there's any urine left behind after you urinate. You can be obstructed and still empty everything, but if you're not emptying your bladder, that's showing us something, that things are progressing worse. A digital rectal exam, that's a finger in the bottom. We're basically feeling the prostate for any hard spots that would be concerning for cancer. And it also gives us just an average, an idea of the size of your prostate. Again, size doesn't always translate to obstruction, but, knowing that you have a 30-gram prostate versus a 90-gram prostate is, can get us going in the right direction. The symptom score, the IPSS, which I think most of you had the option of filling out a questionnaire, it's an objective way that we can figure out if you're bothered and what degree of bother you're having. And that is where we start talking about, would you want to do something about this? Next slide. So what, sometimes we may decide to perform a test that measures the flow. So we're actually determining how fast you urinate, or how fast the urine is coming out of your bladder over time. And that's helpful, as we know that as urologists, we know what is normal and what is abnormal. There are pressure flow studies that are a little bit more invasive, but they're really good studies that can actually, we're putting a pressure sensor in your bladder and measuring, how much pressure there is as you're filling the bladder and as you're emptying the bladder. Because of where the prostate is, right in front of your rectum and right under your bladder, which is of course why we use our finger in the rectum to feel it. An ultrasound of the prostate through the rectum is one of the best ways to image it, and we can visualize the size of it that way by measuring it in a few planes. And then cystoscopy, that's going in with a little camera. It's a little tube about this, I wouldn't go so far as say it, maybe about the size of a straw. It's a plastic coated instrument. Usually we have a little hole to irrigate fluid, and we have another hole that has a light, and we can look through there and see the inside of your urinary tract, and then see the bladder. And that's really important, because we can see, are those walls of the prostate pushing in or not? What does the bladder tissue look like? Does it look like it's getting all those webs? Does it look like it's contracted, that it's already become like a smaller bladder? So those are some of the things that we sometimes want to do as we look further into your symptoms. So the score itself is measures your bother with incomplete emptying, frequency, intermittency, that stopping, start, urgency, weak stream, the straining to urinate, nocturia, which is getting up a lot at night to go, and then the quality of life, which that can be as important as anything because, I mean, I think if your score is getting into the severe realm, but then you tell me your quality of life is 1, which means like you're happy, we might look a little closer even though you're telling me you're happy. But if your score maybe is like low moderate, but yet your quality of life is 5, which would be bad, because you maybe only have one of these issues, but maybe it's so bothersome to you that still, you may want to address that because nobody, we don't want you miserable. Next slide. So what can we do? We can do nothing and hope that it doesn't get much worse, or, decide that maybe later we'll do something. There are medications. Mainly, the main medications we're going to be dealing with are medications that relax the smooth muscle in your prostate and the bladder neck. So it's trying to open things up. And then there is a medication that can shrink the prostate physically via a hormonal effect. And so those are 2 different medications. Occasionally we'll give overactive bladder medications, but that is not treating the prostate. That's just mainly treating a symptom. As far as watchful waiting, like what's the advantage? Well, you don't have any surgery. You don't, of course, you're not taking any drugs. There's no side effects. But you may begin to start altering your lifestyle. You, of course, may very well not have any improvement. Things might get worse. And so then, okay, next slide. As far as medications go, you do avoid surgery, but sometimes it does mask the symptoms enough or treat the issue enough that your symptoms are resolved. But generally, this is going to be a indefinite, daily medication that you take from now on. There are side effects to the one that relaxes your bladder neck. You often will have ejaculatory problems, like may not see any volume in your ejaculate. You can get dizzy. You can have stuffy nose. Some people will go as far as to pass out when they stand up. Some people have had some arrhythmias. And then the hormonal medication can have almost like a low testosterone effect. So you're dealing with, decreased libido, erection problems, lack of energy, occasionally depression. And then, of course, they cost money. So you're going to be spending that money every month for the rest of your life. We can see a loss of effect over time. So that's an issue as well. As far as the herbals, I'm not going to get too much into that because personally, I don't really ascribe much to that. And you're still taking, no matter whether it's an herbal or, one of my issues with herbals is that it's still a drug. It's just something that grew out of the ground, and we don't always know the strengths of those herbals, and we don't have good data to really support them very much. But occasionally, some people do notice some improvement with that. Next. So the UroLift is kind of right after the medications because it is so minimally invasive. We're not. While it is a procedure, we wouldn't refer to it necessarily as a surgery. It can be done in the office with or without, any kind of sedation or anesthesia. We preserve all sexual function, so there's really no risk for your erections, and ejaculatory function is not affected. There's often a very rapid symptom improvement. The recovery is generally very quick. Most people will return to normal activity within 5 to 9 days. There's usually not a catheter involved, although occasionally we will recommend one or place one. And the results are durable, meaning we do have data to support the longevity of this improvement over 5 to 10 years. As far as, one of my old teachers used to tell me there is no free lunch, so nothing's ever perfect. So with this, you do have some discomfort. I mean, it is a procedure. It is in a sensitive area. So usually burning with urination for about a week is what you're going to mainly deal with. Occasionally you'll see more frequency of urination in that early post-op period. Blood in the urine, of course, we're instrumenting the urinary tract. So, there is often a little blood, and occasionally you have to, you maybe rushing to the bathroom initially. And usually all of these symptoms are going to be completely resolved within the first 2 to 4 weeks. Next slide. So there are some other therapies referred to as thermotherapies. We won't go, we're not going to talk about all of them, and some of them have shown a lot of benefit, but they are somewhat minimally invasive. They're in office, often have less permanent side effects than a more definitive surgery, but we tend to see more discomfort with most of these. You definitely have blood in the urine, urgency. These will often have catheters for at least days, and post-op symptoms usually take a little bit longer, like 4 to 6 weeks to resolve. And there is true risk for erectile dysfunction with these therapies. So the more invasive surgeries that we're using to either ablate, kill, vaporize, or resect the tissue itself, these are going to be the most definitive, avenue. You're going to be physically removing the tissue, so you're going to maximize your flow and symptom relief over time. It does remove the prostate tissue physically. The symptom, the improvement in your symptoms do last, and it's less common. It's not very common that you're going to need another procedure in the future. These are almost always going to involve a hospital stay or a hospital visit. You're going to generally have general or regional anesthesia. Often you'll have at least a night in the hospital. Lasers may not always, but I would say that a lot of people that have even the laser treatment will end up in the hospital, even if they're not hospitalized initially. You almost always have a catheter at least overnight, and many people will leave a catheter in for up to a week after these surgeries to let swelling and edema resolve. You're going to need to take it easy for about 6 weeks due to that prostate bed being pretty raw and having the risk of bleeding afterwards. You have up to 10% of patients exhibit erectile dysfunction following these thermal therapies because the nerves that supply your erections are stuck to the prostate on the outside. So it'd be like stuck to the apple on the outside, and you're coring out the apple with heat. And eventually, if you're getting close to that skin or the capsule, that heat will transfer to the nerves and damage the nerves. Many people, I pretty much just tell my patients to expect it, but it's not 100%, but 40 to 65% lose any ejaculation. So they won't see any volume of ejaculate or feel that any longer. Up to 3% will have some leakage following those surgeries. And scar tissue is not, is uncommon because you're going in and out. Again, these are larger scopes that we're dealing with. And so we can end up with strictures or scar tissue that develops in your urethra that then blocks you up. Next slide. So tonight we're focusing a little bit more on the UroLift system. And this is a good cartoon to kind of give you an idea of what we're talking about doing. So your prostate is pushing in on the urethra. So we're going in with a scope and we're pushing that tissue out of the way. We're compressing it and engaging a needle that's going to fire, as you can see in the step 2, it's going to fire through the capsule and engage that tab or a clip on the outside of the capsule. And then there's a suture that is attached to another clip that we engage and leaves that tissue compressed. So, we go up and down, up in and out of the prostatic urethra at varying places, and we'll place these sutures. And you'll see, like this in the slide on the right, we've now got an open channel, and your flow's improved. You're no longer obstructed. As far as what you're dealing with, these are very small clips. That suture is permanent. And then, and as are the clips. The one that is at the capsule is a made of a material called nitinol, and the other is stainless steel, and they're smaller than a dime. This is a video representing what we're doing. So we're going in with a cystoscope, or the outer sheet that is a rigid instrument, and then we can put the delivery device in that, and then we're firing the needle and engaging those sutures, and now the tissue's compressed. And that's the channel, now the open channel into the bladder. Again, this is a real life depiction or picture of after the clips were placed. You can see those little, as the folds that you see are where a clip would have been placed there. And then we've got a great open channel. The little hump at the very bottom of the picture is called the verumontanum. So that's the area where all of the ejaculate enters the urethra, and just distal or closer to the, coming out of your penis from there, you actually have the urethral sphincter, which is, your control mechanism. So that is a landmark that we use we don't really want to come further out from there when we're instrumenting or doing anything to the prostate, because we don't want to injure the sphincter. But given that verumontanum is there, that is why, like during some of these resections and things, we can end up changing the ejaculate. But if we can see from the verumontanum, that little hump, into the bladder, we have found that men will pretty much tell us that they had a lot of improvement in their symptoms. So what would you expect? Realistically, you can see improvement as early as 2 weeks, but sometimes you can see improvement up to 3 months. So I don't get really worked up if a patient isn't coming to me with glowing reviews 2 weeks out, but I will often have patients that do that already. I'm usually expecting people to be fairly happy at around 6 weeks, but we can see improvement up to 3 months. Those side effects that we mentioned are usually mild to moderate. It's usually, it's going to dramatically improve over that first week. My patients that complain of the burning are almost always, that's almost always resolved within like 10 days. Blood in the urine, as long as the blood isn't clotting in your bladder and blocking up your urine channel, it's rare that you would like lose enough blood to matter, but seeing the blood can be alarming for sure. Pelvic pain, so just that deep pain down there, you can have some of that. That's almost always going to be gone within that first week or two. And again, you may have some urgency. Your prostate's been blocking up your bladder for all this time, and now it's no longer obstructed, and so and you also have gone in and instrumented your urinary tract. So overactivity and urgency is kind of how your urinary tract can kind of behave afterwards, and that should resolve quickly as well. Occasionally you can't control the urge, but that's pretty rare. Yeah, like as I said, most of these symptoms are mild and moderate, and within 2 to 4 weeks they're resolved. And we have durability out to 5 and 10 years data for patients that have been followed this long and still have good results. As far as coverage, people always ask, does my insurance pay for it? Medicare definitely covers it. There are copays and deductible that you need to be aware of, and that's where I'm not part of our billing department, but if my patients ever ask about the coverage, I always say, you can get a quote for what you're going to be responsible for. Most, but not all, of the non-Medicare plans or private insurances are going to provide coverage, and our office can work with you and get you to billing and get you to, like I said, get you a quote. We're going to authorize the procedure with your coverage with your company before we do the case. So, you're not going to get stuck with a full bill for this. And again, UroLift.com has, a lot of information. I would recommend you go there with some of these questions as well. It's a good resource. So what now? We can see, we're seeing patients every day for this. I mean, this is a very, very common problem, and this is our bread and butter. This is what we do. So we can, call our clinic, please. You can sign up now. We have telehealth evaluations, but pay attention to your symptoms before you come. Let us know, how you're doing, and just help us find the right solution for you. I have a number of men that come to me wanting a UroLift or wanting a Resume or, some of these different treatment options. But as we work you up, we find that those aren't really the best options for you. So sometimes we do, end up recommending some of those other therapies, and that's okay, because ultimately it's really about what you need. Not, of course, your desire, and you're the one who's going to give consent, but ultimately you want to do what you need, not what you want to do. So, but that's where the evaluation and the workup comes into play. So I don't know if I'm not seeing them personally, but one of my helpers may have some questions from the audience. Okay, so we have had, we've done these meetings before, and some of the common questions, let's see here, that we've had before, it might help you. So real commonly, we'll have patients ask if they're happy with their medications, or their symptoms are controlled by their medications, should they still consider doing something like UroLift, and how long, would I need to be off my meds or on my meds to do something like this? And what if I don't want to have anything done? Well, like I said before, if you're happy with your medications, then you don't have to do anything. But it is something that you're going to be taking for the rest of your life. There are side effects. Sometimes when people talk about it, they actually do say, "Oh, you know what? I do have a problem with that," or "That does kind of bother me." And this procedure specifically is such that you're not really out very much. You don't have to devote the next 3 months to recovery or something like that. It's not like you have tons of blood loss or anything like that. So it's a quick return to normal function, and hopefully getting you off medications. As far as if there's anything else going on in your urinary tracts, kidney stones, some people have prostate cancer that they're undergoing what's called active surveillance. So they've decided not to treat it yet, and they're just watching it. Can you have this if you know that you have prostate cancer, or if you've already had prostate cancer? Yes, you can. Neither of those can, prostate cancer or kidney stones or some of these other urinary issues are not contraindications to this procedure. So a lot of everybody's going to ask, so how long does it last, or is it going to continue to grow? Am I going to have to keep doing stuff? So we have data to support your symptom relief 5 and 10 years. So that's about as long as you would expect from many of the other treatments as well. So again, like I said, you're generally feeling a whole lot better within a week. So worst case scenario is that maybe in 10 or 20 years you might need to do something else, but as long as the insurance will cover it, you can have more. And we have some patients that just want to have more UroLift implants placed, and that's an option. As far as the implant itself, it is permanent. They don't dissolve. We don't need to remove them. We will not remove them. You can have an MRI with them. They're not going to keep you out of an MRI machine because of the implant. As far as whether you're a good candidate for this or not, that's where the workup comes into play, where you're going to need to see us, and we're going to need to do some tests and evaluation to figure out the shape and size of your prostate, tease out your symptoms to confirm that, they don't seem to be from something else. And as far as, UroLift being, why is it unique? Like, what's unique about UroLift? Well, it's the only treatment option that doesn't involve thermal or laser energy, injecting steam into the prostate to destroy the tissue. And again, there are no sexual side effects, and the recovery is very quick. It can be done in office. There is no risk of erectile dysfunction afterwards. And as far as restrictions afterwards, many men are getting right back to fairly normal activity within a couple of days. We don't recommend heavy lifting during that recovery period. Any bearing down can affect blood, can start bleeding in the prostate. But generally speaking, you're not really going to have many restrictions after this. And we have a number of physicians at our clinic that do this procedure. So it's not just me, but we have a lot of options. Many of us can see you and would be happy to evaluate whether you're a good candidate for this. You can visit our website or call us and ask for an appointment. I thank y'all for coming in. I hope this was helpful for some of you. And maybe I'll end up seeing some of you in my clinic. So apparently we have someone that says that they're a patient of Dr. Pruden, seeing him for kidney stones. He's one of our physicians, and he says, can I assume this is a topic to discuss with him? Of course. So Dr. Pruden would be more than happy to talk to you about this, and he's well-versed in the workup and treatment options. So someone's asking how many people have had the UroLift procedure. At this point, we have over 200,000. There are over 200,000 patients that have had this. So this is not like I said, we've got data for many years. These are patients that have been followed for many years. This is not just out yesterday. Our group specifically does about 20 or 30 procedures a month. We have multiple what we call centers of excellence due to the volume of patients that we've treated with this. All right, so I think that everyone's asked the questions they'd like, and if there's nothing more, I just want to remind everybody to call us and book an appointment if you have any. If you're this interested to listen to me yap for 40 minutes, you probably need to talk to a urologist because you probably have some symptoms that need to be addressed, and we'd be happy to help you. You can go to our website and request an appointment as well. We have links for that. But thank you all for your attention, and just have a great night and happy holidays.